Hello, and thank you for joining us today for this Enclave Peer Exchange panel discussion on Global Perspective on Management of Malignant Melanoma. Along with the extensive progress we've experienced in the field of melanoma research comes increased complexity surrounding the optimal use of available tools for treating patients with advanced disease. The goal of this Enclave Peer Exchange discussion with a panel of international experts is to provide clarity and perspective on the latest clinical data and practical advice on how new information applies to the clinic. I'm Dr. Jeffrey Weber, and I'm the Deputy Director at the Laura and Isaac Perlmutter Cancer Center and Professor of Medicine at the NYU Langone Medical Center in New York City, New York. Participating today on our distinguished panel are Dr. Reinhard Dummer, who's Vice Chairman for the Department of Dermatology and Head of the Skin Cancer Unit at the University of Zurich Hospital in Zurich, Switzerland. We have Dr. Axel Hauschild, Professor of Dermatology in the Department of Dermatology at the University of Kiel in Kiel, Germany. Dr. Caroline Robert, Professor of Dermatology and Head of the Dermatology Unit at the Gustave Roussy in Paris, France. And finally, Dr. Dirk Schadendorf, Director and Chair of the Department of Dermatology and Director of the Comprehensive Cancer Center at the University Hospital Essen in Essen, Germany. Thank you so much for joining us. Let's begin. Let's talk about the treatment of locoregional melanoma. So Caroline, when you see a patient in the clinic who has advanced disease but is probably surgically resectable, how do you approach it? That is, how do you decide on resectability?
Well, if we always discuss in a multidisciplinary meeting with the surgeon, and if the patient is resectable, of course, he will or she will undergo surgery. The question is what is going to happen afterwards, because we know that depending on the number of nodes that are involved, the fact that it's microscopic or macroscopic disease, the risk of relapse will be more or less important. And until now, it was very difficult because besides clinical trial, we didn't have really any treatment that was really very effective with a good risk-benefit ratio to decrease the risk of relapse.
Well, but that then brings up the question of, in a day and age when we have effective adjuvant therapy, how aggressive should you be in sampling the lymph nodes? So Dirk, do you always do a sentinel lymph node biopsy? And if it's positive, do you always advise that the patient have a completion lymphadenectomy? So that's a controversial issue. How do you handle this?
Yeah, I think indeed. I think sentinel node biopsy I think is the best prognostic procedure we can do at the moment to find out about the prognosis of our patients. So I think that's a mandatory procedure. Indeed, we are finding roughly, depending on the tumor thickness, up to 25% of the patients that there is some minimal tumor load in the lymph node. The question is, should an elective complete lymph node dissection performed? So the current guidelines at the moment, I think most of the guidelines across the globe are recommending this. There is some upcoming discussion now whether this is always mandatory, whether this also is possibly related to the tumor load in the lymph node. And I think we have to wait for the next scientific results, particularly study initiated by Don Martin, MLST2 study results, which hopefully will give a definite answer on that.
Yeah, it's funny, at least in my institution, it seems like the practice precedes the data. So, for example, a number of surgeons at my institution will decline to do a completion lymphadenectomy if the sentinel node shows microscopic disease. Reinhard, what do you tell a patient who has perhaps a thin melanoma, maybe 1 millimeter thick with no ulceration, and then has a microscopically positive sentinel node? Do you always tell them to have a completion lymphadenectomy?
Actually, this is a very important question, and I have to tell you no. And I think this was still important because in the classification, even single tumor cells are counted as a positive sentinel node, And some years ago, we have done complete lymph node dissection based on this. And we know now that this is wrong because these patients behave concerning their prognosis very similar with patients who have not a sentinel node. So the load is the most important thing. And based on the published data in Lancet Oncology earlier this year, we really have to restrict the indications. And these data that are out there suggest a minimal tumor load of approximately 1 millimeter. So everything that is below 1 millimeter should, in my personal opinion, not undergo complete sentinel lymph node dissection.
I think we have gathered a lot of scientific evidence that actually measuring the tumor load in the sentinel lymph node, whether it's more than 1 millimeter in diameter or less than 0.1 millimeter. So we have 3 different categories. And based on these categorization, which was done by a group in Rotterdam, Amsterdam, and Berlin, proposed this classification, I think is very helpful in finding the category of prognosis for these patients and also guiding us in our recommendations. So the German guidelines now, which have been released over the summer this year, has taken that actually already up, and patients with more than 1 millimeter, there is a stronger recommendation doing
to do the sentinel lymph node. So Axel, if you had a patient with microscopic disease less than 1 millimeter and you advise them not to have the completion lymphadenectomy, how do you follow both them systemically and in the nodal basin? What do you do?
Yeah, let me give one comment to Dirk's German guideline remark, because I think it's important to say that in Germany you need to discuss the issue of the controversy of the complete lymphadenectomy in sentinel node positive patients with a patient if the tumor load in the sentinel node is below 1 millimeter. That's important. You need to discuss it. Sure. Whether the patient is saying yes or no to your recommendation is another issue, but you need to discuss it. That's very fair, and also surgeons need to do it because there might be a conflict of interest, right? But on the other hand, I think it's very important that patients who are refusing from the advice for a complete lymphadenectomy, and there's patients even with more than 1 millimeter diameter in the sentinel node who are not taking, the completional lymphadenectomy, that in these patients you need to have good follow-up evaluations. According to the German guideline, I think internationally it's more or less the same. It's a 3-monthly follow-up for these patients. And we in Germany, as some other European countries, are always using lymph node sonography, which is the most sensitive and specific tool for investigating the sentinel node. Even if you have very sensitive fingertips, and you're not as good as the lymph node ultrasound. And therefore, this is mandatory in these patients. You can pick up the patients with a relapse in the lymph node basin, and then certainly it's a case that the patient is willing to undergo a complete lymphadenectomy. And the vast majority of patients are patients with low tumor load in Germany in the sentinel node, because the tumor load corresponds to the tumor thickness of the primary tumor. And since the median diameter of the tumor in Germany, the vertical tumor thickness is relatively low compared particularly to Eastern Europe, it's not so many patients who have, a high thickness primary tumor, and therefore most of the patients have low tumor load in the sentinel node.
So the irony is, over time, over the last 20 years, it appears as if we've been doing better on surveillance and we've been detecting the tumors earlier. So Caroline, if you...
I would like to also to insist on something. You have to rely on your pathologist. So it's important that you work with a pathologist team that you know, and not all the pathologists would be familiar with looking at the sentinel node. So that's something very important, because we rely a lot on them. So you have to make sure that they process the sentinel node as it should be.
And will you follow these people with any scans, or will you just sonogram the basin?
We would also do clinic and sonogram every 3 months, and we would do some CT scan.
We are doing the same.
Yeah.
I was not saying it because I was thinking about the patients who have not received a completion lymphadenectomy, but all patients in stage 3 receive 6 monthly CT scannings.
For 2 years.
For 2 years, and then what will you do after 2 years?
You know, it's a question. Most of the patients, they like to have more scannings, and if we are doing scannings, we are using MRI, particularly if it's young patients, because we are afraid of the radiation load. And but in most of the patients, we stop.